out from patients and families what they think about the hospice and its services. But the main thing that I want to talk about tonight is actually quite a small part of my role, and that's the oral history service at St Luke's. And that is basically a service that allows patients to make an audio recording of whatever they choose to make, but that could include their life story. Excuse me, I need to get some water. I'm moving my voice already. Sorry about that. I'm suffering with a cold at the moment. You might have to pass my tissues, Stephen. So it's a professional quality audio equipment. We've actually got professional quality audio equipment, so it's like a proper setup that people can have, and it's usually their life story and their memories that they want to record. But we can actually do anything that they want to record. So we did a jam session on the ward last year, which was a country and western singer that we had in, and he wanted me to come in and record all his musician friends singing and playing, which was fantastic. We've also done 4 Desert Island discs, and that's where patients have chosen their top musical tracks and the things that they take to a desert island with them. And what we've done is we've interviewed them like the radio show and put it together, and patients have talked about what they would choose, why they choose to take those tracks. So quite often that actually links in with their life, so they might start off with a track that they remember dancing to as a teenager, perhaps a track that was played at their wedding, that sort of thing. We carry out the interview. It's carried out either by me or one of my team of volunteers, and it's always led by the patient, so they lead what they choose to talk about. It's free of charge. There's no time limit. They can do as many recordings as they like. Obviously, if someone's very poorly, then they might only be able to do a short recording. They might only be able to do perhaps maybe half an hour, something like that. But if they are a little bit more well, we've had patients do 5 or 6 recordings in total. So it's a wonderful service because it gives people an opportunity to put their memories down on record. Some patients do it for themselves. They just enjoy talking, they like chatting, they like to relive their memories. But others do it as a lasting record for their friends and family, and it's something to actually leave behind.
Yeah.
So, yeah.
So that there's lots of positive reasons for carrying out the oral history.
Most definitely, yeah. I think people come into it for different reasons, really. And I think, as I say, we've had a few patients who've been making memory boxes, and they've been making things to leave behind, perhaps for children or more commonly grandchildren. One lady, for example, had 3 small grandchildren, and she wanted to make sure that they didn't forget her voice because they were all quite small. So she did a special CD for each grandchild and put them in the memory box. So she actually spoke to them and talked about what it was like when they were born and things like that. Because for her it was really important that she left something behind for them, basically. So,
and that they could hear her voice and have that.
Absolutely, because the voice is really important. The voice is very evocative, the person's voice. It's something that you can't always capture. And it's something that I think we're better at remembering faces and voices after a person's died.
And what do patients say after they've taken part and after they've done their recordings? Do you get very many comments about it?
We do. We get lots of positive feedback. Patients are usually really glad they've done it. A lot of patients are really happy with the way that their voice sounds. I think particularly when someone is quite close to the end of life, there's lots of changes in a person's appearance. They might feel, they might lose a lot of weight or put on a lot of weight. There might be hair loss, for example, but often the voice doesn't change. I had a gentleman recently in the day centre, and he'd been a Baptist missionary and he'd been a preacher, and he'd had what he described as a very powerful voice. And now he's poorly. He was quite underconfident with his first recordings. He said, "Oh, my voice isn't the same." But when he listened to it, he was like, "Oh, it's great," and he was really confident on his second recording. We took part in a research study with the University of Sheffield to look at the benefits of oral history in palliative care. And what patients said was that one lady from St Luke's described it as like having a good clear out of the cupboard, getting it all down. She did it for her 17-year-old son. And what she said was that she knew that her son at 17 wouldn't be particularly interested in what his mum used to dance to that the youth club now, but when he's in his 30s he might. And also for the children that he might have in the future, the wife he might have in the future, they might be interested So that was the sort of thing that she talked about. So yeah,
that's a really good way to have a lasting memory, isn't it?
Yeah, most definitely. Yeah.
So I suppose one of the things I was interested in, Claire, was how you support patients to actually tell their story. You know, do you find that people need help to do it?
Some people do. Some people just talk and they just go for it. And it can be quite unstructured. So as an interviewer, we need to perhaps guide the person a little bit. And other people need a little bit of prompting. And the main job of the interviewer is to actually stay off the recording, because the recording is for the patient, it's for their family. So they don't want to hear me or one of my volunteers on it. So we ask questions, but we try and use lots of non-verbal communication. But it's all about asking pertinent questions, it's asking relevant questions, it's active listening. So you need a really good memory, because people will quite often give you a potted life history in 10 minutes, and then you need to go back and pick up the bits that they've come up with and think, right, I need to ask them about that, and I need to ask them about that. But it's about summarising, and we usually do it in a chronological way, so starting off when somebody was born and taking them through their lives, that sort of thing. But yeah, so it's sort of just about guiding open questions as well, so asking them why they did that, or how did that happen, or what sort of person was she, and how did you feel about that, rather than yes or no questions.
So it's really thinking about specific communication skills to help the patient tell their story, and to expand and really draw out those memories.
Absolutely, yeah.
The back of the mind.
Yeah, and the sort of techniques that you can use. If someone has lived in the same house for most of their childhood, a really nice way of doing it is to ask them to take you on a journey through that house and describe it. Because they might say, right, I'm going into this front door, and then they'll describe all the rooms in the house, and that can then spark off of the memories that they might have. So yeah, that's way of doing it.
Sounds wonderful.
It's great. I love it. It's the best part of the job, I would say. I wish I could do it all day, every day.
How many recordings do you do? Do you spend a lot of time doing it?
Not really. I'd say that I think last month we did 8, which was quite a lot actually for us. I'd say probably maybe 1 a week, so it's not a huge amount. We get sort of bits and starts of it, and as I say, some patients will do 1, and some might do a series. So yeah, we have.
And how do they find out about it?
We have leaflets available at the hospice. They're available in all of our 3 services, so we can see patients in their own homes, or patients that come to a day centre or on the ward. But we generally rely on the staff to refer patients to us, and quite often it's the staff who spend a lot of time chatting with the patient. So hairdressers, complementary therapists, patients having a massage, they'll open up and they'll talk, and the staff will say, this person's got a real story. And that doesn't necessarily always mean that somebody wants to tell their story. And quite often it's the people who are a little bit quiet who've actually got the best stories. And if somebody says to me, I haven't got much to say, I haven't done much in my life, they're usually the most interesting people actually when you go beneath the surface. Yeah.
That's wonderful. Thank you very much for sharing.
You're welcome.
What I'd like to do now, if that's okay, I'm going to ask you to move to one side, and we're going to get Sam and Ginny to come in and talk to you a little bit more about advanced care planning and preparing for dying. Just give it a short change now. So I'll just introduce Sam and Ginny to you. You probably won't be able to see me very much, but hopefully you'll be able to hear my voice. And Sam, I'm just wondering about how advanced care planning fits with your role. Can you tell me a little bit about that?
It's a seminal part of my role as a consultant in palliative care, because I do see it as my job to help facilitate discussions around planning. It's always on my agenda to be thinking about have these discussions been had, and when is the right time for me to broach those sort of discussions with people.
So it's a very important part of your role.
It's integral, absolutely. Yeah. So people think a lot about symptom control in terms of palliative care, but planning is the other big part of that, and just really having those discussions.
Great. What I'll do is I'll look through your slides. If you just give me a little nod when you're ready to move on. Is that okay? Okay, could you just tell us a little bit about advanced care planning and what that's about?
Sure. So it's really, it's a discussion, and then a documentation of that discussion, and sharing that, whatever's brought out in that discussion, with people that need to know it, about what patients' wishes are about their future care. And I think it's important to explain to people the purpose of it, and it's really to help people make a best interest decision at a time when someone can't speak for themselves. So if they become unwell, for example, with a delirium, or they lose capacity for whatever reason due to their illness, it just helps family members and health professionals make decisions for them, knowing what their views were when they were well. That's really the purpose of it.
So it's really making those decisions, but ensuring that patients are, if possible, when they're well, involved in all of those conversations. It's
sort of recognising that people's view at that time and taking that into context later on. So people often change their views, and it's sort of an ongoing discussion. But and explaining to people that whatever they express their view as at that time, they're entitled to change that view depending on how circumstances change. But it's very helpful to people who potentially come in contact with someone trying to make decisions about them and they don't know them and haven't had the opportunity. So it's really an aid to help patient-centered care and achieve people's goals, and getting people to think about the future in an appropriate way.
I think as well it's important to get people talking about these things when they are in a place where they can talk about them, because if you leave it until they become less well, then it's more of an emotive situation, and it's harder to make those decisions because they've got a lot of other things to think about as well. And the earlier people make these sort of decisions, even though they might change over time, then the easier it is on the bereavement process sometimes for other people as well.
So it sounds like it's almost the start of that process, isn't it, of thinking about dying. But it is a process, it's not a one-off conversation, it's about...
It's an ongoing conversation because people won't imagine the number of things that they will have to decide or that they will want to make choices about. So if you get them at the right time, and particularly I had a discussion earlier today with someone about she was telling me about her grandmother who had discussions as an ongoing process, and it became a bit of a joke in the family in a way, not in an unpleasant way or unfriendly way, but by the time that person's grandmother died, they knew her wishes, and it actually impacted on the bereavement process because they knew exactly what she wanted. And then the same thing happened again. History sort of repeated itself because the person I was talking to, her mother made her own decisions. They were different decisions, but because she recognised that it had made things easier for the rest of the family, and they'd actually done what that person who died wanted. It's a really useful thing to do when you're not involved in all the emotion of the situation when somebody becomes ill and you've got a lot of other things to think about as well.
And imagine having that comfort and knowing that decision is the right one.
Definitely,
So was there anything else you wanted to add about the goals of advanced care planning, what we're aiming to achieve in advanced care planning?
It's individual for different people, but there are sort of key themes that come up, and I think people have had the opportunity to reflect on their own sort of potential preferences and wishes throughout the week, and it'd be interesting to hear from people, whether there's something that I've missed that I should be discussing. But the key themes are really around escalation of care, where people want to be cared for, how they want to be cared for, things that they definitely wouldn't want to happen to them, things that they do want to happen to them, who are the important people to make decisions, help make decisions for them, who to involve. And it's difficult to predict every situation that could arise, but sometimes in specific disease situations, you can make an educated guess about potential dilemmas that we might come across, and then it's about acknowledging the uncertainty of that, but then making a contingency plan. Because often when the planning process doesn't happen ahead of time or isn't communicated properly, then I have seen many times where people, for example, are taken to a place of care where it's clear afterwards that they wouldn't have wanted that to happen to them. Or when they lose capacity and then family members and those closest to them have never had that discussion and they don't know themselves, so it's really hard to work out what's best for that person.
I think as well, as healthcare professionals, we act as the advocate for our patients, and quite often if we don't know what patients want, a certain person who's struck up a rapport with the patient, healthcare assistant, a nurse, a doctor, any member of the MDT team, they might think that they know what that patient wants because they've got quite involved with them over a number of days, weeks or whatever. And it might be different from what the family think the patient wants as well. So again, it's just so important to know what that person wants.
Yeah, and one thing I've learned is very much not to assume, that somebody would want this to happen to them, because you get surprised time and time again. When you think you know someone well, actually when you ask them directly in an open way, you'll be surprised actually their preference is something quite opposite to what you might expect. Which just highlights the importance of having those conversations, because when someone loses capacity, we're left to have to make an educated guess as to what they would want.
I suppose it's not assuming, it's being open and demonstrating that you're willing to listen. I think that's really important, isn't it?
Yeah, without any sort of preconceived ideas about what's best.
I think it can be really hard for everybody. My background is obviously nursing, and I've been involved with a lot of patients over the years who've died. And when you just think back to the situations that you've been in, and when you found things out at the last minute sort of thing, and it can leave you with a feeling that you've not done your best for that patient. If you find something out and it's too late to put it back to do what they want, it's not a nice feeling to have. And you do learn from it, you reflect on these things, but you've not got it right in that case, and that's hard.
Sometimes I'll say, well, hypothetically, if something changed unexpectedly and suddenly next week, what regrets would you have? Who had you not spoken to? Occasionally that does happen. You think we've just missed an opportunity. And I think often these conversations are kind of left to somebody else, and that's why I encourage people to take ownership of it and feel confident to have them, because in the research it very much shows that the majority of people want the opportunity to talk, but they won't bring it up themselves. They're not sure when the right time is, if it's appropriate, who the best person to talk is, and there's no correct answer to that. It's just seizing an opportunity. But it's also not forcing that conversation, because not everybody wants to have it, and it's not always the right time. So it's just giving people the opportunity to have that discussion, but then also giving them the opportunity not to have it, and want to give the opportunity to do it.
So it's not prescriptive.
No.
It's about responding to the patient's needs and their wants. I suppose a little bit touching on the next point. I suppose going back to what you're talking about, it's this process that you go into. It's not a one-off event, these conversations, and it's about the skills that you have as practitioners in supporting the patient to actually open up and have those conversations.
It can be a number of conversations, because you can have your initial conversation, and then you leave the patient to think about what's been said, and they need you to repeat things to them. They think about it some more, and a plan is developed from there.
Sometimes it's just raising specific questions that might want to be thought about, and then giving people space to discuss it with the key members in their family, because they're not always present. But it's encouraging that open and honest discussion, and facilitating that, because sometimes we find people protecting family members, or family members protecting patients, and it's amazing the power of bringing that out into the open, and the relief that sometimes gives when people understand.
I can imagine that is not enormous relief. I'm just wondering if we could move on to the next point, which is about DNA CPR. It's something that we haven't touched on in the cost so far. So I wondered if you could tell us what that means.
Sure. It's something that's often misunderstood, not only by the general public, but also by healthcare professionals, I think. And I guess why, in a hospice context, we try to make a proactive decision when someone comes into our care, whether we think cardiopulmonary resuscitation or restarting someone's heart or breathing if it was to stop, whether that would be an appropriate thing to do or not in the patient's best interest. What's the chance of success it would have in bringing someone back to a functioning that would be acceptable to them? And when you look at the literature on chances of success, saying it's out of cancer, it's very, very small. And you look at what does success mean? It means being coming back to life with a quality of life that will be acceptable to the patient and achieve discharge home. And it's not really like it's portrayed in the media on these medical programs where people sort of suddenly come back to being fit and well again. But it's really a decision that's usually a medical decision, but sometimes it's important to involve family and patients in that decision-making process, particularly where it's unclear if it would be of benefit. And if we think that it may have a chance of being helpful, then that's the time when it's most important to discuss it and involve patients in finding out what they would want, because actually at times where I think I would consider resuscitation, many people, when you talk about it, say that's not something I would want to have. But then you're still respecting patients' wishes and document it's part of advanced care planning in that context. But it's misunderstood because often it's taken for something that it's not. It's literally a decision about whether you would start with CPR. It doesn't mean that we were not going to treat people in other ways. So in terms of people get it confused for decisions to provide antibiotics for sepsis or to provide nutrition and hydration or other aspects of medical care, and it's not to be confused in that way.
So it's quite important, isn't it, that distinction and that decision that is made by the doctor, that it is communicated where possible with the patient.
It shouldn't come as a surprise to anybody that they weren't resuscitated when that time comes.
Right, I think you kind of probably addressed a question, but I suppose I was interested in how you go about that communication process.
I can't remember a time when I've had an isolated discussion about resuscitation, because it forms part of a bigger conversation about escalation of care. So when someone's coming to the hospice, very much, what interventions would you want us to do? Would you want transferring back into an acute hospital setting if you became unwell? Would that be appropriate? And thinking what they could offer outside of the care that we can provide. And often the decision becomes obvious because the patient's wishes on other aspects of advanced care planning leads to a clear preference on resuscitation. But at other times, when people do want full active treatment, and that's appropriate, then, but I personally feel that resuscitation wouldn't be of benefit, then that's usually just explaining my thought process, my rationale behind it, and all this relies on people having a good understanding of where they are in their disease and their overall health. And that can usually be done by discussing those surrounding subjects, and then it's rarely a difficult discussion when you do it in that way.
And in your experience, that tends to be how that conversation will manifest itself as you continuing that process of advanced care planning. That will come into the conversation.
And I have seen at times where people have avoided talking about it, hasn't been thought about, and people have had inappropriate resuscitation attempts, and it's not a nice thing for a family to have to go through, to see, because it can be quite a traumatic experience, even if the patient themselves is unconscious, people witnessing it. And, yeah, so if that's really the dignity of the patient comes paramount, and if we can avoid inappropriate attempts, then that again helps the grieving process.
I think so, and I think, you know, what Sam said about this not being a topic that's in isolation. You know, the discussions are generally around taking the cues from patients, listening to what they say and establishing what they already know. You know, you'll get questions like, they don't want to, well, they'll say things like, I don't want to die in pain, how will it be at the end? You know, asking me those sorts of things. And this is all part of this conversation, explaining what is likely to happen, and then talking about CPR, DNA, CPR, all those sorts of things within that conversation, and saying how we will care for people when they do reach the terminal phase of illness as well. But you do base it on what your patients ask you and talk to you about, and things that are sort of hidden in conversation. You have to really listen to what they're actually trying to find out. But again, like Sam says as well, we don't always want to know.
Yeah. And it is being checking out what they do want to know.
Exactly, it's being sensitive to what they want to know and not giving them information that they really don't want as well.
Yeah. Thank you. So, just kind of recapping, I suppose, a little bit about how you introduce the conversation. And I suppose we've already covered some of this to a degree, about the timing of these conversations. And you've already mentioned about picking up the cues from patients. But is it something that you kind of build in, you know, you have at the back of your mind when you're working with patients?
Yeah, and the earlier the better. Because then you'll have more opportunities to open that discussion. And there'll be clearly bad times to have this discussion. And, you know, often, you know, when someone's first been given a diagnosis, you know, they're not going to be able to participate in a discussion like this. But it's, you know, you get a feeling for when the right time is, and it's about just taking opportunities. Sometimes when there's been a change in focus of care, there's been some significant news about, say, there's no more treatment options, or you know, significant hospital admission that's led to, you know, various experiences. There'll be a follow-up plan, and it's like reflecting on those experiences. And I think that's often a time when people are feeling a bit better. You know, it's catching them in a moment where they've not got everything else going on. It's capturing their, you know, their attention and their views, you know, when they're feeling well enough to discuss things.
It is. I think it can be quite challenging sometimes in the respect that, you know, we're just talking very much from an inpatient perspective, but we see a lot of community patients as well. We've got a community team, they go out and see patients, so they will go out for appointments, and these conversations sometimes you can't time them for exactly the right timing to the patient, so that can be quite difficult. But they have techniques, they're used to doing it, they've got good communication skills, so
yeah. Because there's really a time when this is your primary intention. You know, unfortunately, everyone's so busy dealing with acute issues, and but actually we're not resourced to like make a specific visit to do advanced care planning usually. So it's usually on the background of we're dealing with something else, and then it's easy to then focus on that. But as I said, people want to have the opportunity to have these discussions, and they take time. And I think that's another reason why it's no such thing as a quick, you know, 5-minute discussion. That's if you're going to start talking about it, you need to be prepared to spend, you know, a good half an hour up to an hour discussing these things. And I think in our specialty we're lucky that we often do, we can afford that time, and it's I think that, you know, we're in often a good position to be able to do it.
Thank you. Okay, I'm just going to move on slightly because I'm aware of the time. I'd like Julie to ask you, if it's okay, to tell us a little bit about staff looking after their own well-being. So when you're engaged in these conversations, how do staff get support for themselves?
Well, we're very well aware of the burden that staff carry, but it's not just about the nurses, the healthcare assistants, the doctors, it's about everybody who is patient-facing. And for us, that actually involves hospitality staff, housekeeping staff, social workers, a whole range of people. So that basically I manage the nursing team, and they get a lot of peer support. They will talk about things on a regular basis, going through, throughout the shift, and it can be things to do with symptom management, end of life, and patients are deteriorating. They're very expert in knowing what medication will work with other medication, and will address certain symptoms, and if that doesn't work you move on to this. But it's always really good to have somebody else there as well, because you've got the emotion of the situation which you have to detach yourself from and be professional, and that's what we expect from the whole of the nursing team, and all the other staff within the hospice. But so I suppose what I'm saying is that we support each other, and when they've got a particular challenge for various different reasons, then they do get support from each other. Sometimes that isn't enough. That sort of will be the first point of contact, because the colleagues are around them and working with them. So we do have reflective meetings, which allow group discussions. You can discuss something that is just relevant to you, or something that's bothered you or upset you, or that you just found particularly difficult. And it might not be the same thing as somebody else finds difficult, but it prompts conversation between the whole group, and they work really, really well. And what it actually makes you realise is that day after day we work with people in these distressing situations, and while it can be immensely rewarding, it can be a burden to carry as well. So sometimes there is further support needed. So the reflective meetings work quite well, because it helps people to realise that you're all working towards the same goal. And for me as a manager, it makes me immensely proud of my team and other teams within the hospice, just to hear what people are doing, just as a matter of course. This is what we do day in, day out. We have a good chaplaincy team, and that's a really good support for a lot of staff, and they will go and get that support just when they need it. And the person that leads that team is always available, or always seems to be available. And he will provide the support is needed, and that's all confidential. But then, as a manager, I monitor the team and know where they are, who's studying, who's not. Generally, and people only can come to me, but we direct them in other ways through our HR department. So there are things like counselling that they can access, and various other therapies. If we think we need something more, there's obviously occupational health and their own GP and people like that. But we put as much support in place as we can at the right time, and then support those people through that. Because while, say for instance, if somebody is accessing counselling, then we know that, then we keep an eye on them while they're at work. If they're not well enough to be at work, then they go off work, but then they come back to work, and obviously it's important to monitor those people to make sure that they actually are coping. Then, sometimes it might be a training need as well, and there are things that we can do like that as well.
It must be really good for a member of staff to know that supportive environment is there, and that the support needs are acknowledged and recognised as being important.
I think one of the things that I've realised over the years is that if somebody's off work because they're ill with a broken leg or something like that, or a pain, you know that they're ill. If it's something psychological, then sometimes people can feel as though they're a bit of a failure, and sometimes people don't come to you at the right time because they think, I should be able to cope with this, everybody else is managing. So for me as a manager, it's recognising if somebody isn't coping and making it alright to talk about it, really.
Yeah. What about you, Sam? Making the support available?
I've certainly used the chaplaincy team in the past. It's someone sort of outside of the my direct team that I can debrief. And it's having support outside of your workplace, I think, as well, is very helpful. And it's recognising the signs in yourself when you're not starting to cope so well. So, if you're not sleeping well, you're taking some patients home with you, which you wouldn't normally do. These are the early warning signs that you might just need to debrief or think about why is it affecting me in that way. Because being able to switch off from work and have downtime is important to allow us to keep caring into the future.
And this is something that we talked a lot about on the course, how important it is to be self-aware and acknowledge that you need support. One of the things I was wondering was about how do patients get support, or if they have support needs, when they've had conversations like the ones we've been talking about. How do you pick up those pieces if patients do want to talk more about issues that come up following the conversation?
When we've had these conversations, then we do revisit them because, as I've said, it's an ongoing process in any case. And quite often you'll find out that a doctor might have gone in and done a ward round and had these discussions, and then the nurse will go in and they'll say, I don't really understand what we were saying, and that's because they've not been able to think about the whole of that conversation. They'll just have picked up on certain bits and not have got a full understanding, even though at the time of the conversation you might think they have. So I think it's reaffirming what's being said, explaining what's being said, and to do that you've got to share the information with the team, you've got to communicate well with each other, and we've got various methods and ways that we do that, and we work very much as a tight-knit MDT team, and so that will involve various people, the obvious, the nurses and the doctors, the social workers, wellbeing team, all those sorts of people, and they will also support patients through these discussions as well. But it's making sure that we've got the right information, and I think we do that quite well through handout sessions, but mainly through our MDT meetings, which are very focused on the issues that are the main concerns of patients, not what we think the main concerns are.
It really is working well as a team, isn't it? The other thing is we don't want to burden people with unnecessary conversations and repeat things over and over again. So it's communicating really well as a team and picking up the bit, knowing everyone knows the bits that their role and basically working all towards a common goal for the patient. And I think having that MDT meeting really helps us achieve that.
Thank you. Okay, I'd like to invite Claire back into the room, and we're going to sort of squeeze in a little bit. And we've got a few questions that we can respond to. Okay, this is a question for Sam. How is everybody in there? Yeah. How do people react in general when you discuss DNA CPR?
Generally, they understand. Occasionally you do get a differing of opinions. Sometimes it's when, for example, a family member sort of is in conflicting views with the patient as well. And it's often when people aren't ready to let go of their relatives, and they see this as sort of a life-sustaining measure that may be helpful when it's a differing view to the medical team. And usually with time and explanation, people understand. But very, very, very rarely, and this is the concern of people, people don't like talking about it, is when you come to a true conflict and people, they're really hanging on to that as being something that their patients need. In that situation, I'll offer a second opinion, so getting someone else to come and put fresh eyes on that situation. Usually that will then resolve the issue, and needing to be flexible in that. Occasionally, if there's still resistance, really it's been clear that we try and take the family along with us, but at the end of the day it has to be what's in the patient's best interest. I think it's highly, I can't even remember a situation actually where I had to go down that road, but it's very rare. Okay.
Another question for you, Sam. How do you cope with a patient who is not happy to have this discussion?
I'm not sure what was. We're talking about advanced care planning.
I think perhaps, yes.
Yeah.
Yeah.
Yeah. Sometimes it can be about taking permission from the patient to have some discussions with family members instead if they don't want to be involved in the process. And that's okay. You know, if people show initial resistance to it, it's about giving them an opportunity, you know, chance to change their mind and gently persuade them. But that's usually only if there's something really holding back their care, because it's about them, it's about what they want to do. So if they don't want to talk about it, then that's okay. You know, and we can make it can be just about talking about best interest decision making and how we would do that if they don't want to express their wishes rather well. And there's a process for doing that. They shouldn't be forced into discussions that they're not comfortable with. Again, occasionally, if someone's in like a denial process and it's causing friction within the family because of different opinions, then you need to carefully craft that and encourage that conversation more proactively. But generally speaking, it's not an issue.
And another question, just to follow that up, ladies. Whose responsibility is it in the community to document DNA CPR? Question mark the GP.
Currently, it does stand with the GP, but there's a shared form in Sheffield, where we are currently, that can be transferred from one care setting to the other. So it's the responsible clinician. So if someone's been under my care, then I can fill it in and it goes with them, and then, you know, copy will go to the GP, and so they'll be aware of it. So it really depends on the situation, but it's the responsible clinician looking after the patient. There is talk about nursing, specialist nurses being able to completely force, but that's an ongoing discussion and varying opinion on.
And also on the same topic, contextualised resuscitation decisions are coming from the Resource Council. Will this help?
I'm not aware of them. I'm just referring to sort of specific cases, hypothetical cases to help aid.
Perhaps the person who asked the question could just clarify that for us, and we'll come back to that one if that's okay. Can I just move on to Ginny, just to ask you a question, Ginny. What are the views about clinical supervision of staff?
The views from who?
I presume it means from the staff.
Yeah, well, from the staff, we've recently investigated this and the staff welcome it. We started clinical supervision in one of our teams and we're making steps towards that on the inpatient centre for the nurses and healthcare assistants on there. And this is why at the moment we're doing a reflective meetings to find out what sort of supervision would be the most appropriate. As an organisation and for me as a manager, it's clear that we do carry an emotional burden and this does impact on some people more than others. So I think it's a really important issue and it's something that we are looking to introduce.
Yeah. Thank you. Claire, got a couple of questions for you.
Okay.
Do other hospices, or how many other hospices, have similar services?
Oral history, well, very few actually. There's lots of oral history projects out there, quite often focusing on a particular group of people, so maybe people in a particular battalion in the war, or Jewish refugees, etc. But in palliative care it's quite new. I mentioned earlier the University of Sheffield project study that we took part in, and that was actually part-funded by Macmillan, and they're using that as evidence to fund some more oral history services in other parts of the country. We're really lucky in Sheffield because we've actually got a similar service at the palliative care unit at the Northern General Hospital in the city, so we've actually got two oral history services, whereas most cities in the country don't have any. But I would hope that because we've been able to evidence the benefits of it, that there's going to be a lot more set up because I think it's a really valuable service. And one of the things I would say is if anybody's interested in setting up an oral history service in their own area, is to look at the Oral History Society website. But in palliative care, it's all about starting early. Just as with the discussions about DNA, CPR and advanced care planning, we sometimes get patients referred who are very poorly and they're very frail and they can't record as much as they would like, they're too fatigued. And it's actually the patients that start making the recording early that are the most pleased with the result. So I would urge anybody, if they're going to make an oral history recording, do it as soon as you can.
And would the community nurses refer patients to use that service? Yes,
they do. We can go and see patients in their own home. Sometimes that's a benefit because patients are often surrounded by their own things, they've got their own memories, patients are a bit more comfortable in their own homes. Often it means the volunteer stays for a bit longer, so it usually takes a bit more time, but certainly, yes.
How much editing would you need to do if taking a recording?
Very little editing, because it's patient-led, so it's patient's recording, so it's whatever they want. So if the patient wants it editing, then we will edit it. Very occasionally, I've got some very sophisticated editing software, so I can see. I had one patient, for example, who had a big leg cramp in the middle of the interview, and you could actually see him going, I was interviewing him, and I said, I think we'll take that out, so your wife might wonder when she listens to it, what's going on. But you can actually see it come up on the recording. But most patients are happy with what they've done, so we usually leave it as it is. Sometimes patients get carried away in their recordings, and they reveal a little bit too much. It can be a very cathartic and consolidating process, but they've often said things that they perhaps don't always want their family to hear, so they might ask us to go back and edit. We had one gentleman who was having some problems with his memory, and he was talking about that on the recording, and he said, I can't remember what I had for breakfast, but I know all my computer passwords, and that last bit's this. And then you realise afterwards that, of course, we need to go and take them all out, just in case the CD comes from our hands. But generally, it's as it is, because it's the patient as they were on that day, and it's recording is for them.
Do patients want to put their story on YouTube?
Oh, we've not had anybody ask. We've mooted the idea of video recordings, but actually, what I mentioned earlier about patients with altered appearance, they're quite self-conscious in front of the video camera, particularly if their appearance has changed. And very often they say that their voice still sounds like them, even if they look different to how they used to. And also the recording equipment we use is very discreet. It's a little lapel microphone, and you usually forget to put it on. But if you've got a big video camera in the face, it can be quite inhibiting. Most patients do their story for themselves, but we have had a few that like it to go a little bit wider, so we sometimes play some recordings at events and things like that. But we've not had any YouTube stars yet, but you never know.
Maybe it's the way to go. Sam, is it okay if I revisit that question we asked? Rhesus Council are developing them now, it's on their website.
Certainly the Research Council have got some good guidelines on DNAR decision making, which I'd urge people to look at. I wasn't aware that they're making these slides, and I'll be interested to see them myself.
Okay.
So I haven't seen the new scenarios, but whatever I've seen from the Research Council previously has been very helpful.
Good. Okay. How do you handle the situation when somebody wants to be resuscitated when it is known it would be futile?
I think we've sort of covered that in a way. If people are, I think defining futility can sometimes be difficult. Obviously, it's clear cut in many cases, but there's always a grey area, and it's acknowledging that. If someone is sort of determined, once you've explained all the risks and benefits, I mean, occasionally I do have people who, there's a 1-2% chance that they might come back to a reasonable quality of life. They've perhaps been resuscitated before many sort of months or perhaps years ago, and they've benefited from it, or they've known someone that has, their prognosis is sometimes not as clear. If it's one of those situations, then there's no right or wrong answer. And if there is a small chance and they're wanting to take that, then sometimes we say that that's okay, you're for resuscitation. If it's really medically inappropriate and it's clear cut and people are insistent, then I'll offer a second opinion. But those, I think if you explain it clearly and you give reason for your decision, then people understand that.
Yeah. And I think that's something that you've explained very well, that you do need to give that information.
There's no point in saying it's just futile. It's about explaining why, how you've come to that conclusion.
Okay. So we've had this question a couple of times. So, have you audited the care of those regarding DNA CPR? Is there any evidence that in hospitals they give less care if DNA CPR ordered present?
That's a very good question. I'm not aware of an audit locally where we've looked at that. There's certainly a perception that can be the case, and I think that's a fear that patients have. But again, it comes down to good documentation. So if it's a decision taken in isolation and not a clear escalation plan been written and discussed properly, then yes, perhaps. But you can reassure people that, if what they want is everything up to that point, then that's clearly documented in the handover. And I'll occasionally write on the DNA CPR form, for full escalation of care, but not for CPR, so that if someone comes and reads the form, then it's clear therefore. It's actually communication.
I think that's something that comes across from all of you talking this evening, about this communication, how important that is across the team, and that any decisions are communicated to everybody involved in the patient's care.
Thinking about that would be a very difficult thing, I think, to audit. Because measuring the outcomes are kind of a little bit nebulous. It's difficult to design an audit that would test that theory accurately. Something to think about.
Okay, so we've probably got a couple of minutes left. So we've got another question coming, so I'm just waiting for that. So you've all been very patient with us, and it's really great that you've had the opportunity to ask so many questions. So this is to Sam and Ginny. What is the most effective way to document decisions about end-of-life care planning?
In an ideal world, and I think in the future, there'll be sort of electronic communicating systems. That's a real frustration of mine, is that sometimes decisions made documented to the best of people's ability but not shared, because the technology hasn't always allowed it. We've been promised this universal sort of electronic system that has never really arrived yet. And I think it will come, but it's knowing who needs to know, and making the best.
I think that's the case. I think we've got documentation standards, but it's not just about writing it down, although it is very, very important to have the right information written down where the relevant people can access that information and understand it. It is about verbal communication as well, and this is something that we've talked about NDT meetings and things like that. And so whatever is written down is also discussed in NDT meetings.
Because, like a discharge summary from the hospice, for example, will have all this on it, but doesn't always get to everybody. So out of our services are a key player in this, and it's about communicating well and fostering a good relationship with them, giving patients and families ownership of this as well, so that, when they come in contact, sharing that information by copying them into letters and asking them, do you want to be included in this? So they can actually have a copy of it and bring it wherever, if it's really important to them, so that they can share it as well. But thinking, should it be shared with, who should this information be shared with? And I think in the future it will be much easier. And in Sheffield we've got a good communicating system within our own service, but we're not always the one that needs to know.
Yeah. Wonderful. I'd like to thank everybody for their contributions. I think it's been a really interesting conversation, and it's been a delight to have you all here. Thank you very much. So, unless there are any more questions, I think we'll finish there. No? Thank you. So I'm just noticing there's a few people typing away, so we'll just hang on a couple of minutes just to see what comes from that.
Thank you.
All right.
Okay, goodbye.
So what would you advise us and our friends and family to do right now about advanced care planning while we are well?
I think the key thing for me, while I'm well, is actually giving the people that I want to make decisions for me the power to do so, and doing a power of attorney for medical decision making is something I would encourage people to do. And there aren't many people that do it, and I think it's not a difficult thing to do. You can do it without it. It's a little bit expensive, but that's certainly, there's places on that to officially write down, what you want. There's also a process of making that decision to refuse treatment if you have strong views. That things you don't want to happen, because then that is a legally binding decision where it's like assault to do it otherwise, and you can be prosecuted if you were to do something that was against someone's advanced wishes. But really, it's about opening the conversation with people close to you, and then there are tools that you can use to facilitate that discussion, like the Preferred Priorities of Care document in the UK, which is freely available on the internet, just to sort of stimulate that discussion. But I guess you've done exercises in the week where you've thought about what would you want, but trying to put yourself in that place, which is not always easy.
Yeah, I think participants will be doing that, if you haven't already, it's an opportunity for them to think about that a little bit more. So thank you for everyone for your questions. It's really been a fantastic learning opportunity for me. I'd just like to say good night to everybody. We're going to log off there now. Thank you.